Hello, everyone. I am very honored and pleased to introduce our keynote speaker, Dr. Mark Lewis. I only know Dr. Lewis through Twitter, and he is a very prolific tweeter about his own experience as a patient and as an oncologist. He's the director of gastrointestinal oncology at Intermountain Health in Utah. And I'll put a link to his Twitter feed so you can follow him if you don't already. There's a lot, I learn a lot listening or following his Twitter feed. And I'm not going to tell you too much about him because you have his bio, and I'm going to let him tell you in his keynote presentation. But Dr. Lewis, thank you so much for being with us today. We're really grateful. I know you're very busy and appreciate you taking time out of your day to be with us. And also, happy birthday. I think it was your birthday last weekend, right?
Yes. Oh gosh, you're so kind. Thank you so much, Shelley. What a lovely introduction, and I'm so grateful, frankly, to receive the invitation. I think your cause is very near and dear to my heart. So just in terms of housekeeping, I think I'm going to run my own slides. Is that right?
Yes.
Okay. So we can jump right in. I think my talk will take somewhere in the order of 30, maybe 35 minutes, and then we should have time for questions at the end. Okay, there we go. All right, so the title of my talk is The Fortune and Folly of Self-Diagnosis, and there's a little bit of a spoiler alert right there. So if we go to the next slide, please. Okay, so I know this is a deliberately shocking image and person to invoke at the beginning of a talk, and that's by design. I'm a big believer in public speaking. You want to grab the attention of the audience right away, and I'm not sure there's a better way of doing that than talking about Joseph Stalin. And I want to be clear, this man was a monster. One of the worst figures in human history. You can attribute to him tens of millions of deaths, which is an odd place, I know, for an oncology talk to start. But here's my point. He knew that we have a disconnect between our head and our heart. He knew that numbers can only take us so far, and some numbers get so big that they become literally incomprehensible. So as he was committing all these atrocities on a truly grand scale, he said this really chilling quote. A single death is a tragedy and a million deaths is a statistic. And listen, I'm an oncologist, as was mentioned in the introduction. I quote numbers at patients all the time, trying to give them a handhold, something less abstract, something a little bit more concrete, especially as they're weighing, say, risk and benefit. But what I've realized as I do this, as I sit there in my white coat and I do this, I realize that, frankly, the much more powerful vehicle in my mind is storytelling. So with your permission, I want to tell you a little bit about a family, and I'll forewarn you that it's something of a tragedy. So if we can go to the next slide, please. So Zach, with apologies to you, there's going to be a bunch of bullet points. I'll just cue as we go. So, in oncology, we talk about the index patient, sort of the first patient in a family who comes to medical attention. And in this family, it is the gentleman pictured on the left there. So he was a minister in Belfast. He was a Protestant minister. He was actually very important to the peace process as the Troubles erupted and Protestants and Catholics in Northern Ireland in particular descended into sectarian violence. And he was really well known for his sermons. He was a very gifted preacher. He would usually memorize his sermons, and frankly, he had most of the Bible memorized. But then, for a man who, public speaking was really his bread and butter, he started having a hard time talking. And that progressed to difficulty swallowing. Next. And then he started forgetting things. Like he would actually forget his sermons, which for him was a massive source of embarrassment. And as his doctors worked him up for this memory loss, he was found to have brain metastasis. Although I'll point out at the time, the primary tumor where the brain metastases came from was actually unclear. Next. Unfortunately, he died at age 64, really without a firm diagnosis. So keep him in your mind. We're now going to move to one of his sons. So next slide. His older son was 42 years old. Next. And he was a lifelong non-smoker, and that's relevant because, as we'll see in a minute, next, he was in his usual state of health. Next, when he underwent a chest X-ray, this is a little bit unusual part of the story. His new job actually required him to get a chest X-ray, and he felt okay, but his chest X-ray looked like this. Next, there we go. And you don't have to be a radiologist to see the problem here. So famously, the lungs should be full of air. On X-rays, air is black because it allows the X-rays to penetrate straight through. And you can see in the top right portion of this man's lungs, there is a giant mass that is opacified. So it is not allowing the X-rays through. Next. So his past medical history, this is important to kind of put this into context or not, the only problem he had been dealing with prior to this was for about 20 years, basically since young adulthood, he'd been having kidney stones. And it didn't matter what he did in terms of diet. He was told by his doctors, ingest less dairy. Didn't matter. The kidney stones kept on coming. And for any of us that have experienced those, that's actually a profoundly painful problem. Next. So in terms of what happened to him, next, his family were told that this was lung cancer, and I'll use air quotes. Next. His treatment was pneumonectomy. So this is a really radical operation. He had the entire right lung removed. He was a man with a way with words, and he said that he began the slow puffing process of proving its redundancy, meaning he was able to live off of his left lung. Next. But this is key, the surgery was not complete. So despite removing an entire lung, some of this tumor, this cancer remained behind his breastbone. And so this was the late 1980s at this point. He had adjuvant radiation to that area, that mediastinal area behind the sternum. And that was thought at the time to be enough. Next. Okay, and there it says in the title slide that he developed a relapse, unfortunately. So several years later, he was on holiday with his family. Next. He developed severe back pain and x-rays, and I apologize. This is literally a digitization of a plain x-ray from 1991. So what I'm trying to show here, and I don't know actually if it projects very well, this is a side-on lateral view of the spine. I think especially if you look at, say, that lowest full vertebra, the one near the bottom, and kind of squint, you might get the sense that the white is actually speckled or stippled with dark and black. What I'm trying to show here, maybe not terribly successfully, is that the cancer that had been behind his breastbone actually spread through his bloodstream and created this problem of incredibly painful bone metastases. Next. So he began a chemotherapy that actually we would still use today in this circumstance. So that lung cancer we talked about earlier was actually technically a neuroendocrine carcinoma, much like small cell lung cancer, actually. And so his treatment, again, would actually look very similar today. It's cisplatin etoposide, which is profoundly myelosuppressive. It decimates the immune system. Next. And so he nearly died after the very first cycle of chemotherapy. This is obviously both a patient and an oncologist nightmare, and nearly died of infection because he had literally no white blood cells. Next. But that week, this is truly providential, that week his oncologist came into the ICU where this man was literally on his deathbed and said the FDA just approved a new drug called filgrastim. Many of us will know it as Neupogen. It is a white blood cell growth factor, sometimes also known as GCSF, granulocyte colony stimulating factor. Regardless, this brand new medicine given to this gentleman brought his immune system back from the brink. Next. So in terms of further history, he had disease stabilization after 6 cycles of cisplatin and etoposide. So the chemo did what it was supposed to do for a duration. Next. But, and this is all too typical of this particular cancer, more metastases developed after 2 years of relative dormancy. So he was in remission, but his doctors were very wary that this could come back. Next. So he moved to a new chemotherapy. Next. And this is where timing was not on his side. So he died within the first 8 hours of his exposure to this drug, paclitaxel, which may also be known to many of you. So this is a drug that really is sort of a workhorse. It is active in a variety of different tumors. We use it sometimes in breast cancer. We use it in lung cancer. We use it in prostate cancer. But at the time, paclitaxel was interesting. I sometimes have patients come to me and they say, Dr. Lewis, I want a natural therapy. And I say to them, listen, you got to be a little bit careful saying that because while natural sounds more benign than something artificial made in the lab, it isn't always. So at the time, this was 1994, paclitaxel was made directly from the bark of the Pacific yew tree. That's what you can see in the background there behind the molecule. And that meant it was incredibly allergenic. And so this man died of anaphylaxis because this chemical was so prone to provoking allergy. Now, these days, even now, paclitaxel is semi-synthetic. It comes in a special diluent called cremophore. And even with all of that, we still give high-dose steroids before chemotherapy because the risk of an allergic reaction is so high. Next. Okay, so finally, I want you to keep that very first patient in mind. Now we're going to talk about his younger son. Next. So his younger son, 5 years after his brother's death, developed these really profound headaches and visual changes. And if you hit the button next, we'll look at what those look like. So imagine you're actually looking out through this man's eyes. And what I'm trying to show you here is he developed tunnel vision. He lost his periphery. This was actually a problem. This is not funny at all. He was a driving instructor, and he lost his job because as he was instructing students, he himself was clipping the mirrors of parked cars. He just couldn't see them. He had no awareness that they were there. And what was causing this was a very large pituitary tumor that was growing up from his pituitary and pushing up on the optic nerves as they come back and cross en route to the brain. So it's a very specific pattern of loss called bitemporal hemianopsia. Next. So again, MRI scans at the time, this was now the 90s, showed that this was a large pituitary tumor. Next. And as the sort of bad luck continues to befall this family, these days is actually a very routine operation. It's usually performed by sticking some instruments very delicately through the nose and accessing the pituitary gland that way. And sometimes patients go home the same day. This patient did not. Next. It was complicated by hemorrhage. Next. And he died within days of pituitary apoplexy, basically very sudden loss of the pituitary gland, and that was associated with a stroke, and he passed away. So now I've told you about 3 men in a row, all related, a father and 2 sons, with extremely different and all basically inexplicable medical catastrophes that cost them their lives. They ranged in age, they ranged in age at time of death from 49 to 64. Next. So finally, that first patient's grandson. Next. So 50 years after his grandfather died, he developed abdominal pain when he was 30 years old. Next. Some very basic blood work showed that his calcium level was high, not sky high. And I'm going to show you this x-ray. Yes, thank you. So here, what's interesting is that the problem is not now above the diaphragm. It is below the diaphragm. So the chest is clear, but if you see below the diaphragm on the left in particular, there's these massive loops of bowel that are filled with gas. And sometimes we talk about gas as if it's a really sort of mild symptom. This is pretty significant here. This is an ileus. The high calcium level here has paralyzed the bowel, so it's not moving. And that's where the abdominal pain came from. Next. So his history, was there anything else, any other clues to what was going on with this young man? So 2 years prior to the onset of his abdominal pain, he developed these tiny red bumps over his nose. Next. And this is actually not him. This is a picture from a medical journal. If you look at the nostril there's this little kind of fleshy bump right at the entrance to the nostril, and that is called an angiofibroma. Next. And a dermatologist, when he met this young man, immediately recognized that. It's a very small, benign, but vascular tumor. So if you push on it, it blanches and then blood fills up again. So again, it does kind of look like acne. And the dermatologist told him this. He said, this is pathognomonic for tuberous sclerosis. Basically, you must have tuberous sclerosis. So this young man went home and he looked up tuberous sclerosis and he said, that doesn't fit me. It doesn't fit my family. That can't be right. There is something wrong here. Next slide. And that young man was me. So I was in my medical training at this point. I like to say I knew just enough to be dangerous. And I knew that I could not have, nor could my family have, tuberous sclerosis. I knew enough about that disease, which is horrible, by the way. So the tubers in tuberous sclerosis are these potato-like tumors, which sound very benign, almost whimsical, except they can form in your brain. And especially in children, they tend to cause seizures. They tend to cause significant developmental issues, and they can even result in mental retardation. So this is not the pattern of tuberous sclerosis. This is the pattern of multiple endocrine neoplasia type 1, or MEN1. And I know it sounds arrogant for me to say. I don't like to describe it as my eureka moment. That sounds like some sort of flash of genius. This was when I finally was able to put the clues together and realize what was wrong with me, and in hindsight, what was wrong with my dad, my uncle, and my grandfather, all the men I told you about. So the calcium, it turns out, of all, was the key. So once I knew I had calcium, and I knew that my father had suffered from high calcium, I knew just enough. I knew there was 2 conditions, 2 only, that would cause high calcium in consecutive generations. One is entirely benign. It's called familial hypocalciuric hypercalcemia. It basically means you don't put enough calcium in your urine, so it builds up in your bloodstream. Causes kidney stones. That's about it. But all these tumors and weird cancers that were happening to my forefathers, my literal forefathers, they fit the bill. So my dad, like I told you, had a very weird neuroendocrine tumor grow in his chest. My paternal uncle, the driving instructor, he had the pituitary macroadenoma. And then I can only surmise that my grandfather, the great preacher with the booming voice, I think that the reason he lost his speaking ability is he probably had a tumor grow behind his breastbone too, maybe thymic, maybe bronchial. But putting it all together, this is the pattern of MEN1. And I'm the proband because although I'm not the first patient affected, I'm the first patient in this whole kindred to recognize this is what we have. Next. So I'm going to talk to you as a group of patients and advocates now about the tricky business that I think you'll appreciate of self-diagnosing. Next. So here's the thing. This is the DSM-5. This is like the Bible or the encyclopedia of psychiatric illness. And that sounds like a weird thing to invoke, especially about myself. My point is hypochondriasis is a mental illness. Thinking that something is wrong with you when it isn't, that's a problem all of its own. Next. But one of my favorite books ever written is Catch-22. And among many, many quotable lines in the book, there's a sentence that says, just because you're paranoid doesn't mean they're not after you, which means that you can suspect on a deep level there's something wrong with you, maybe something doctors are missing, and you can be right. Next. So when I was figuring all this out, I actually was beginning my training at the Mayo Clinic, sort of a world famous center of excellence, including diagnostics. And I went to my primary care physician that I'd be assigned, and I said, hey, listen, you might think I'm crazy. He did. And I said, listen, I think I have MEN1. I think I have multiple endocrine neoplasia type 1. I just started oncology here. I'm pretty sure I have it. I'm pretty sure my dad had it. And listen, in fairness to this doctor, this is how I would describe myself objectively. A 30-year-old doctor starting his specialized training in oncology convinces himself he has a tumor syndrome. Okay. So in fairness to him, what would you say? Next. Would you say this is nerves or something worse? Well, you don't have to say that because the New York Times said that. Next. So I wrote up my experience in a medical journal, and as best I could tell, nobody read it, which is fine. But I kind of self-disclosed that I figured out this MEN1, and I basically wanted other people to know the pattern. And about a year later, I got this call from someone that at first I actually thought it was a prank call. They said, we're from the New York Times, we want to write about you. And I thought, yeah, sure you do. And it turns out it was this wonderful doctor. Her name's Dr. Lisa Sanders. She's an internist at Yale. Most famously, she was the medical consultant behind the series House. And as you may well know, brilliant show. The whole kind of point was this genius diagnostician who could, sort of summon the right answer when other people missed it. So anyway, Lisa, Dr. Sanders was very, very interested in sort of real life house style cases, and she thought mine was one. So when she wrote up my case in the New York Times, she called it nerves or something worse. Was I anxious about starting fellowship, or did I really have something wrong with me? Next. So one interesting thing about this format is a month before the story is published in actual print, the New York Times puts all the clues online and then lets their readers guess what's wrong. And I want to be crystal clear, especially to this audience. I'm not making fun of anybody, okay? But my point is this. The people that were guessing what was wrong with me had all of the facts that I've already given to you today. And it was an open book test. They could go to Google, they could go to PubMed, they could use whatever they wanted, and then they could submit their answers. And I'm just showing you what people in the public thought was wrong with me. It ranged from I was, following the wrong diet, to I was taking too many Tums, which is actually a pretty good guess, to it all being on some level either psychiatric or psychosomatic. So here's my point. When we are trying to investigate these things on our own, we all need a little bit of professional help. I know I did. And on the other side of the table, I know from personal experience now how difficult it is not to be listened to by your doctors. It's pretty famous with these rare tumors that patients might go to half a dozen specialists over the course of 5 to 7 years before they get the right answer. The right answer, of course, being key to the right treatment. And that can feel, and can be in real life, can be lost time. And I think that's really frustrating. And I think it can result in a lot of mistrust, perhaps founded mistrust in the medical community. Next. So what's really interesting is, I just want to say really briefly, I won't bemoan the point, but so MEN1, my syndrome, is actually known by all medical students. And I'll point out, I was taught about MEN1, and I didn't realize that I had it, okay? Because I was anchored on this mnemonic. So the mnemonic is the 3 Ps. Next. So the three P's in MEN1 refer to the alliterative mnemonic of the pituitary, the parathyroid, and the pancreas. It's really nice, easy to remember. All the organs are in the midline. Those are the big three organs that are affected. But here's the problem. The disease doesn't know this is our memory device. There's other tumor types that go along with the syndrome. They just don't fit the mnemonic. You can go ahead, Zach. So bronchial and thymic carcinoids, adrenal cortical tumors next. And then on the skin, as I mentioned, and this may seem really almost superficial or vain, you can get these red spots in the middle of your face. Those are the angiofibromas. You can get cholangiomas. You can get these really large fatty tumors called lipomas. I know you know what lipomas are, but I'm talking massive. Like I had to have one removed from my back because every time I was working out, it was literally getting caught between my shoulder blades. It was huge. It was probably about this big. Next. So what I'm trying to show you with this pie chart is even a doctor that knows MEN1 or remembers it from the board exam can still miss some of these less common but still important clues. And that's exactly what happened to my dad. So his oncologist was excellent. I still think he's a phenomenal doctor. He totally missed MEN1 because my dad didn't fit the classic manifestations. And so, you know, when we talk about rare diseases, we sometimes are looking for the common manifestations of rare disease. But being rare already, you can have a rarer manifestation of a rare disease. And as patients and advocates, you all know that. Next. And one more. Okay. So there's this whole business, especially in neurology, it's called localizing the lesion. You may be familiar with this exercise. So what it means in neurology is really dating back to the era before we could do scans of the brain. Someone came in with, say, a sudden change in speech or a cranial nerve palsy. You had to, just on the basis of physical exam, because this was a black box, figure out where the problem was. So what I'm showing you here is I actually know where the lesion is, not in my brain, but in my genetic code. And this is a very recent revelation. So real quickly, the human genome absolutely fascinates me. Long before I was a doctor, I was in high school. My science teacher said, Mark, what do you want to study this year? And I said, I want to learn about the human genome. And I didn't even know that there was genetic illness in my family or in my future. I just found it fascinating. So in the 1990s, the Human Genome Project took basically a decade and billions of dollars for scientists all over the globe to figure out what does a normal genetic code look like. And once we knew what was normal, now we can determine what is abnormal. So you have to define what's normal before you know what's abnormal. It's like with art, you have to know the rules before you can break them. So what I'm showing you here is actually my own genetic code. And this is actually almost scary. So there's a single spot on the long arm of chromosome 11. That's what I'm showing you here. We all have 23 pairs of chromosomes. This is the 11th one. So in the long part of that chromosome, there's a single spot, okay, where two letters got deleted and one got inserted. This is out of 3 billion letters in total. That alone is enough to give me my disease, okay? And there are so many examples in medicine of the fact where a single mutation, single deletion, insertion, what have you, can give you an entire genetic condition and one that can claim your life. That's just how fragile and tenuous we are. It's actually kind of amazing how well we work. So now I know this, okay? Next. But if I had gotten smarter about my family, next, and specifically if I'd started looking into this before 2007, and you'll notice that day is bolded in the bottom right reference, I would have been told, even if I did genetic testing, that I did not have this mutation. Because it was only in 2007 that the specific mutation that runs in my family was described in the literature and thus indexed in a testing database. My point with all of this is not to give you all the gory details about my broken genome. My point is, I had all the clues and later the symptoms that fit MEN1, and yet, if I'd gone through with formal genetic testing before 2007, I would have been told I didn't have the condition. The reason I'm telling you guys this is we have to persist, both as patients and in advocating for patients, in believing people to a reasonable degree when they think that something's wrong. Okay, even when I'm taking care of patients now, I'm giving them chemo, I might see them weekly. I tell them all the time, you live on a continuum. I get to see you in a punctuated equilibrium. So I will believe you when you tell me something is wrong and I will investigate it. Next. Okay, so again, I won't belabor the point on this. So phenotype, genotype correlation, what that means is, can you predict based on the mutation? And again, I know exactly where mine is now. Can you predict what's going to happen to you? And as you may have already surmised from my family history, the answer is actually no. So Zach here, I think you could probably hit it like 4 times. So these are all the men I already told you about. My granddad, my dad, my uncle, all different. And then finally, buried in the appendix of that 2007 paper, there's a single man in Sweden who also has our mutation, who doesn't look anything like us. So for me, this is both a good and a bad thing. The reason it's bad, or at least frustrating, is I can't look at my mutation and say, okay, I'm 45 years old. Thanks for the birthday wishes. This is going to happen to me when I'm 50. This is going to happen to me when I'm 60. It doesn't work like that. Okay. I have no idea what's around the corner. On the other hand, that means I have a little bit of control over my own destiny, and these things are not a foregone conclusion. So I actually take more hope from that than I do frustration that I can't see too far into the future. Next. Okay, so first things first. So I was symptomatic from high calcium, so the first thing I had to do was remove my parathyroid glands. And the reason I'm showing you this picture, other than the fact that I look fantastic in a surgical cap, is the surgeon that did this operation said to me before the surgery, he was one of my colleagues at Mayo, he said, Mark, if you don't mind, what I'd like to do is I want to videotape the operation so I can show it to other people later. I said, that's totally fine. You go right ahead. And the reason that's important is we'll get to is what I did later when I had another surgery. Next. So really quickly, for patients with my condition, the reason this is all really important is when you fix the parathyroids, you're actually fixing things elsewhere in the body too. So the thing that's beautiful and amazing and complicated about the endocrine system, and the reason endocrinology is its own specialty, is chemical signals from one part of the body can have drastic effects on other parts. So surprisingly, but we've known this since the 60s, the parathyroid hormone can actually control your stomach acid production. So if you control the parathyroid hormone overproduction, you can actually lower stomach acid. So this is a very old school graphic, believe it or not, from the New England Journal of Medicine in 1969. What they're showing you here on the graph is a patient who undergoes parathyroid surgery sees immediate drops, not just in their gastrin, that's the white bar, but also in their calcium, which is the shaded bar. Next. And then again, the other reason this matters is before about 1990, the main cause of death for people with my condition was excessive stomach acid. So people were dying in droves, either of stomach ulcers that caused them to bleed to death, or actually rupture or perforate the stomach, both horrible ways to go. So you might imagine I was pretty concerned with controlling my stomach acid. And now, since 1990, we have drugs like the H2 blockers, like your Pepcid. We have the PPIs, like omeprazole. And what that has done is it shifted the cause of death from these horrible stomach ulcers to now pancreatic tumors. So neuroendocrine tumors that grow in the pancreas are actually the #1 threat to the mortality of someone like me. And there again, rather than Sweden, I look to Northern Europe. Our Dutch colleagues have actually rigorously followed huge Dutch families with my condition, and they tell us exactly the threshold of concern. How big does a pancreas tumor have to get before it's likely to metastasize and kill someone? Next. So once I'd figured out my parathyroids, and I'm a GI oncologist, mind you, my attention turned almost exclusively to my pancreas because I was like, okay, this organ isn't bothering me yet, but this is the organ that is most likely to kill me. So this is my first endoscopic ultrasound. I'm deliberately showing it to you this way because I want you to have some appropriate respect for what gastroenterologists are doing here. So they are both proceduralists who have a scope down your throat, and they're real-time radiologists. They're reading to me what looks like a snowstorm. This is like a blizzard. Even now when I look at this, I'm kind of amazed at what they can discern. You can see the report below. That is the text description of the black and white stuff you can see up top. And really what that's all saying, my entire pancreas is abnormal. The whole thing. That's not a surprise. I am genetically abnormal. I'm a mutant. My programming is broken, so my pancreas is also flawed throughout. The only fix for this is to have my entire pancreas removed. And of course, there's reasons I don't want to do that and didn't want to do that. Next. So what did I do? I followed my pancreas every single year using an ultrasound. So they would put an ultrasound down my throat right next to my pancreas, so no radiation exposure. Come to that later. And I saw in the summer of 2017, I saw one of these tumors and had my pancreas double in size, basically. And that's when I knew as an oncologist and as a patient, it needed to come out. So I'm sorry if I'm grossing anyone out here with literal gross anatomy, but this is my pancreas being flayed open. So on the left, the head of the pancreas is still intact. That sort of weird sort of half ring of tissue around it, that's the intestine that's been cut open because the pancreas sits in the first curve of the small intestine like it's occupying a C. And then on the right, the pancreas is being cut open to show you the tumor. So that was my Whipple surgery back in 2017. Next. So this is the Whipple. I have many patients even now who have the other form of pancreas cancer, pancreatic adenocarcinoma, could be cured, but are too afraid of the surgery because it is a profoundly complex surgery. It's a very difficult surgery to recover from. So this is my analogy. Bear with me. I like to say that the surgery does to the abdomen what Picasso did to faces. Okay, that's why I have the Picasso on the left. You can recognize the elements by the time the surgeon's done, but they're all in the wrong place. They're all rearranged like a cubist painting. And the anatomy on the right is what I live with now. It's what I've lived with for 7 years. Next. So what I decided to do was, okay, if this procedure is so scary that some of my patients won't go through with it, what if I could make myself an example? And there's no nobility in this. I waived my confidentiality a long time ago. I thought, what if I could actually share my surgery step by step? And of course, my surgeon had to be on board with this, and he's a remarkable man, and he was. So that's him there on the right on the day of our surgery. And using our institution social media team, we documented the entire thing. So it was mentioned at the top that I'm very active on Twitter. This is far and away the craziest thing I ever did on Twitter was have my entire surgery live tweeted. And it was a remarkable experience. And the kernel in my brain was having had that earlier surgery videotape because I thought, if this surgeon at Mayo wants to videotape my parathyroid surgery and show it to his fellows, that's great. But what if I could literally open myself up to the world? And that's what we did. When I woke up, 3 million people had been watching my surgery, which is just, to this day, blows my mind. Next. So they documented step by step, almost like an instruction manual, how the Whipple went. I think there's something like 60 or 80 steps, something like that. And here's my thought. I really do believe that monsters are more scary in the dark. You can break down almost anything into, if you'll forgive the pun, digestible components. And that's exactly what we did on the day of the surgery. Now there's a document that even I refer to with my patients now, showing them how the Whipple is done. I kind of feel like it's a magic trick. Once you know how it's done, some of the mystery gets peeled away. Next. So again, we put it all out there. You can actually, if you're so interested, there's a link at the bottom, which is obviously not easy to remember, but the entire sort of compendium of tweets in that day is archived online, and that's been nice to refer to. Next. Okay, so obviously I have long, again, since waived my privacy. I'm way out there admitting that I have this because I have the privilege of doing that, okay? So if any one of your doctors violates your confidentiality, and I'm not pulling any punches here, that's a fireable offense. I've seen people literally lose their jobs decades into their careers by committing HIPAA violations. Usually it's an accident. Sometimes it's intentional. Either way, the whole point of medicine is you have to trust us. You come into these cold rooms in flimsy gowns. You might literally or figuratively expose yourself to us, and we're supposed to help you. The bedrock of that entire relationship is trust. So my point is I gave up my confidentiality over 15 years ago. I know I'm lucky. My employers have never penalized me for doing that. But I know that many of you might feel otherwise, and that's why I feel like I've got an important platform. So call me an exhibitionist if you want, but I'm going to make full use of it. And so I've told my peers, I was like, listen, you guys have to understand, I'm an oncologist. It looks a lot different to me now, my field does, when I'm a patient rather than just a doctor. Next. Okay, so this is the Roman god Janus. In our English idiom, being two-faced is a bad thing. It usually means you're lying, you're talking out of both sides of your mouth. I'm a believer that actually this is a really interesting perspective that I have sort of stumbled into as I can see things as both a patient and a doctor. It actually means that some of the things my colleagues do drive me crazy. One of the phrases I hate is manageable toxicity. I don't know if you guys have heard that. It's unfortunately been in vogue the last couple of years, especially in oncology. To me, the question is always, who, pray tell, is managing this toxicity? Is it you, the oncologist? No, it's usually the patient that has to deal with it. So to me, that's a phrase that means we're sort of sweeping potentially serious side effects under the rug, and that really, really bothers me. Next. Now, to get kind of end on a philosophical note, and hopefully there's at least a couple minutes for questions, there is one way I could look at this. I could say, ME1 is a family curse. It killed my dad. It killed my uncle. It killed my granddad. Next. I'm dealing with the ramifications of this. Next. And then I've got my kids. So to any of you that are parents, I think you'll understand what I mean when I say I would much rather go through something myself than watch my children go through with it. And sorry, I'm a little teary now. The fact that I've gone through this makes me hope and think that my kids won't have to. Next. So finally, this is the pedigree by which I learned MEN1. This is how I was taught it in medical school. Really quickly, this is the first pedigree ever done on an MEN1 family. So a couple things to note here. Between the circles and squares, you can tell this condition can affect men and women equally. The black or cross-hatched circles and squares are people that were dying of stomach ulcers. And then finally, if you count out everyone in this pedigree, you'll see that almost exactly half of the people were dying of this disease. So it's autosomal dominant because there's a 50-50 inheritance rate. It doesn't matter if you're a man or a woman. And then at this time, people were dying in droves, typically before age 40, of lethal stomach ulcers. That's how I learned about this disease. This, however, is how it looks to me now. So these are my children. This is a very old picture, probably about 10 years old. The way I took this picture, by the way, was I didn't take it myself. I left my laptop unattended on my kitchen table, and then I let them take the picture. They were very interested in doing that at the time. And my reason in showing this to you, I'm pulling your heartstrings on purpose. This is what 50-50 odds look like to me now as a parent. So, basically you're flipping a coin every time you conceive naturally as to whether your child will have it or not. That's how this works. And I'm happy to tell you by looking at them, I don't think you can tell who's affected and who's not, but the affected child is my son, Alan, named after my father, on the left. Next. Okay, finally, I'll say as a parent, I used to adhere very rigorously to guidelines. These are the 2012 guidelines as to how to follow, particularly children, and there's a lot of labs and a lot of scans involved here. Next. But what I want to say to you as a doctor, as well as a fellow patient, is there's this quote from Shakespeare from Othello, where he talks of one that lived not wisely, but too well. What I'm getting at here is we can actually put our patients at risk by over scanning. If you look at the left here on the graph, a single whole body CT, one of them, puts you within 1/5 of the radiation exposure that is allowed in the United States by someone that works in a nuclear plant. Okay, that's one CT scan, all right? So you can see how quickly this radiation exposure is going to add up. So my point is, yeah, I want to know what's going on with myself. I want to know what's going on with my patients. One point of advocacy that I think is potentially rated or overlooked is radiation exposure next. So there's this principle of ALARA. We should be thinking, how do we make radiation exposure for our patients as low as reasonably achievable? Next. And then finally, I'll say these scans also have a psychological effect. So what I'm showing you on the left and showing you on the right, believe it or not, exactly the same patient, just scanned in a different way. So with modern scanning techniques on the right, you can see that they are absolutely riddled with bone metastases. What's interesting, though, is in this patient, those bone metastases are completely painless. They're asymptomatic. But now you've shown the patient this, and they're like, oh my gosh, I'm absolutely riddled with disease. I'm going to die. So there are real psychological implications that I realize more as a patient than as a doctor for ordering these scans. Next. So finally, I'm going to invoke my father, and bear with me if I get a little emotional here. While he was dying, he wrote a book, and I could actually hear him write it. So his study was through the wall from my childhood bedroom. He wrote it on a typewriter. Next. And it's a very dense theological book, but there's a couple quotes in it that I always like to cite at the end of a talk like this one. So one thing I want to get at is he was very selfless. And rather than saying, why me, he said a much more realistic question is, why not me? Why should I be exempt from the floods and famines, the accidents and disasters that bedevil my brothers and sisters? By what extravagant mercy have I so far survived, that to which so many others tragically succumb? That's the way I feel. Next. Go back one, sorry. Yeah. Grounds for gratitude multiply. Spine-tingling miracles of providential timing. Remember, he was saved by Neupogen. The banter and much laughter that frequently echoed through the valley of darkness. Some people think I'm silly for an oncologist. I think humor is a coping mechanism. The discovery with family and friends of whole new levels of resourcefulness and love. I've tapped into a network that includes the very group I'm addressing right now. And the opportunity, however brief or lengthy, to discard the trivial and the shallow and to fill every moment in relationship with meaning, intensity, and value. Next. So I'm going to end there, and I apologize. I probably have taken up all the time I was allotted. I just want to thank you guys so very much for letting me talk. I don't often get to do this in a professional setting. I definitely spoke to you more as a patient and an advocate than I did as a doctor. But I want you to know, I believe patients. I really, really do. In fact, I think the onus of proof, the benefit of proof, burden of proof is on us as doctors to prove what's going on. Like if you come to me and tell me something's wrong, you better believe that I'm going to take that at face value, and within reason, meaning I don't want to harm you, I will investigate until I have found the problem and ideally fixed it. So finally, this is my whole Whipple experience. So on the left, the morning of surgery, you can tell it's the morning because I'm still smiling. In the middle, that's when I got out of the hospital. You'll notice that little tube in my nose that stayed in there for 5 weeks. So I never take open nostrils for granted anymore. That moment on the right, that's the moment that tube came out after 5 long weeks. Literally, without exaggeration, one of the greatest moments of my life after marrying my wonderful wife and having my wonderful children. So with that, I'll end. And again, I apologize if I went slightly over.
Thank you very much, Dr. Lewis. That was amazing. I knew it was going to be amazing, but it was even more amazing than I thought. I really appreciate your story, and
Thank you.
it's totally fine to get choked up because I always say if we get to the point where we don't get choked up by this stuff, when we become too jaded and need to hang it up. But I don't think that's ever going to happen for me,
Agreed.
at least, and
Agreed.
probably most of us here. I want to ask you, we have time for a couple quick questions, but
Great.
I want to ask you, I love what you said about believing your patients. And, we do our survivorship survey every year. And a couple of years ago, we asked about misdiagnosis and delayed diagnosis. And of course, for young adults, because the rates were extremely high
Yeah.
because they're not believed or they're told, you're too young or whatever it might be. So I love that you tell your patients that you're going to believe them. And what's your advice to people who don't have a doctor like that? I mean, I guess it's to find one, but like, how do you cope with that if you don't feel like you're being taken seriously?
Well, I think as a concrete example, I might actually bring up young people. I think that's great. I think there's this still, even among doctors, there's this really outdated notion now that cancer is just a disease of senescence, that it just happens to older patients. So one of the reasons I moved to Utah is it's the youngest state in the country. The average age here is 30. 1/4 of the population hasn't finished 12th grade yet. That's how young the state is. And my wife's a pediatrician, so that's great for her. She's got lots of patients. But here's my point. Even with that, the average age of one of my patients is 68. So I've got this super young population. Cancer, especially the type I treat, still skews older. But I think as we get the word out there that cancer, in fact, can very much happen to young people, this is not going to happen overnight, and it's definitely going to be a group effort between organizations like yours and outspoken oncologists like me. I guess what I would tell patients in particular is don't think that this is all in your head. Okay. And the most recent example I can give you, I literally met this young woman yesterday. This young woman, I won't obviously give you her personal details, but she was so tired. She was so tired. And one little clue that's actually really important is she was craving ice all the time. Okay. So she went to the doctor and they found that her hemoglobin, this is true, was 6. Okay. And this is on a scale where it should be at least 12. And the doctor said, oh, it's because you're young and you're losing too much blood with your periods. And this young woman is resourceful enough that I can only imagine this was awkward. I'm a man. She went to her friends and said, hey, like, how much blood are you losing every month? And they kind of compared notes about, pads and tampons. This woman's like, yeah, it's not the menses. That's not where my hemoglobin got down to 6. So she persisted and persisted and persisted and kept bringing up the ice thing until somebody finally said, huh, I wonder if we should scope you. And lo and behold, she had colon cancer. Okay. Now, is there selection bias here? Absolutely there is. I'm a GI oncologist. This is who I meet. But every time I meet someone like this, I'm like, man, we have got to stop thinking about this as, oh, you get to 50 and all of a sudden you get colon cancer, or you get to 45. Like any one of us, and this is both scary but also important for this discussion, any one of us can get cancer. My youngest patient's 50, my oldest is 106. So it's almost a cradle to grave problem. And thus we need to take people more seriously. And then finally, I just want to say very briefly, I do feel sympathetic towards primary care doctors. I think they have an incredibly difficult job. The best analogy I heard is actually in a book. I think it was called How Doctors Think. It came out about 20 years ago. And in that book, Dr. Groupman, the author, says, being a PCP, what that means is you're standing by a railroad track and a train goes flying by you. And you have an instant to glimpse faces in the windows of the carriages. And you have to pick out the one person that day that's really, really sick. I think that's a perfect analogy for being a primary care doctor. The problem is that means that you have to have your guard up. And what I mean by that is being diagnostically astute and saying, maybe this young woman with a hemoglobin of 6, maybe it's not just her periods. Maybe we do need to do something else. And it's funny, this young woman's husband was sitting with her and he said to me, he said, Dr. Lewis, if I went in with a hemoglobin of 6, what would they have done to me? I said, well, they would have immediately scooped you because you would have had no other source of blood loss. So,
Yeah.
I know I'm picking a very specific example. Of course, it's one that's top of mind and close to my heart. But I think there's increasing, and I want to end on a hopeful message. I think there's increasing awareness among doctors, including our primary care doctors, who are kind of the gatekeepers to all this, that these problems can happen to young people. They can absolutely happen to young women, who I think are probably the most vulnerable to being under or misbelieved. And it's only by sharing our stories that we can raise the level of awareness.
Yeah, that's a great note to leave it on, a happy or a positive note that I
Yeah.
think people need to
Yeah.
advocate for themselves. Can I ask one more question? Is
Of
just
course.
how do you deal with the emotional toll of both taking care of patients and losing patients, and also kind of knowing that you have this to deal with, that you have to continuously monitor and all of that?
Yeah. Gosh, I'm trying to think of how I can make this advice for other people that doesn't sound trite. I guess I would point to my dad, who I quoted. Humor, I think, is helpful. It's funny. I had a student following me a couple years ago in clinic, and we got to the end of the day, their first day, and we'd seen like 20 people. And I said, "What surprised you the most?" And they said two things that were just beautiful. They said, "There's a lot more hope," and they said, "There's a lot more laughter."
Mm.
And I think those two things go together. And I think it's hard because Twitter is a platform that's largely shorn of tone. Like, you can imagine in your mind whatever the person is saying. You can imagine tone. You can imagine that's malicious. You can imagine that's inappropriately silly. A lot of the feedback I get is, "Oh, you're not serious enough for an oncologist." I'm like, I'm pretty serious in the clinic or in the hospital when I'm telling someone that they're dying. For me, it's a coping mechanism, and I think that when we share that with one another, it can actually be really beautiful and a support that sustains us.
Great. Thank you
Yeah.
very much. Really appreciate it. Um, we'd love to have you back another time. If
Yeah.
you mostly talk to doctors and you want to talk to patients, we're happy to have you anytime. So thank you for sharing your story. There's a lot of really wonderful comments,
Yeah.
and we appreciate your time.
Thank you guys so much. Really appreciate it.
Thank you.
Nice.